Hello, everyone. This is one of the recorded lectures that I will have. Hopefully, it's pretty short. This is going to be on medication administration. And a little background again, legal responsibilities. You can see what healthcare providers are legally permitted to write scripts or prescriptions in the United States. So, with nurses, you're going to have advanced practice nurses amongst this list. And what else are they responsible for? Obtaining clients' medical history and physical exam, diagnosing, prescribing medications, monitoring the response or the effectiveness to the therapy, and of course, modifying medications as necessary, depending on are they effective or not. Nurses are responsible for preparing, administering, evaluating. It's the whole gambit once they have got the order in their hand. Developing and maintaining an up-to-date knowledge base of the medications administered. Again, if you do not know what the medication is, stop what you're doing. With your phones now and the computers at your fingertips, much easier than it was years ago for us to look it up. So you have to know the mechanism of action, the routes, safe dose range. If all of a sudden, most doses of morphine are somewhere between 1 and 3 milligrams, even 5 milligrams, 10 is very, very high for morphine. So, and you'll learn this as you go. But if you're much over 10, you're going to wipe the respiratory tract out. Okay. Also, determine accuracy of medication orders. Reporting all medication errors, very, very important. You can't just not report it. Prescribing, dispensing, and administering of medications is controlled by federal, state, and local laws, the healthcare agency policies, and each state's Nurse Practice Act. So very, very important. If you don't understand what the Nurse Practice Act is, you need to get a copy of it. This is very, very important that you understand the Nurse Practice Act. They do change from state to state. Written policies, types of medication orders. We've got routine orders. Routine means they're going to be given on a routine basis. They may not have a termination date. The order may be in effect until the primary care doctor discontinues it or the client is discharged. A single one-time order means it's given at one time and only once, as soon as possible. It might be they're giving a diuretic just one time because they need to pull fluid off. It may not be repeated. Stat order means now. It's given now. PRN we touched on a little bit last time I had you, which means as needed. So it's at what dose, what frequency, under what conditions a medication may be given. The nurse uses clinical judgment to determine the client's need for the med. Maybe something like a Tylenol, 325 milligrams oral, every 3 hours PRN for pain. So that means that we're not just going to give it every 3 hours. We're going to use our judgment and do they need it? Do they need it? That's what PRN is, as needed. And then standing orders may be written for specific circumstances or for specific units. Coronary care unit, CCU, they have specific orders for somebody who's having an MI or heart attack. The ICU has standing orders for somebody who is, having a stroke, brain bleed. OB, where I used to work, where I ended up working in the last several years, we have standard orders for a postpartum hemorrhage. That just means they're in a policy somewhere, and they're standing orders, meaning they have to be looked at every now and again to, put a current date on it that it's been looked at and evaluated, but it means they're current. Components of a medication order. What do we need to see? We obviously need the name of the client or patient, the date and the time of the order, the name of the medication. It can be generic or a brand name or the trade name that we talked about, the dose, the route. It all goes along with those 6 rights. The time and frequency, exact or number of times per day, and the signature of the person writing the order. Physiological variables affecting medication order response. How old is the patient? Remember, the older they are, depends on if the GI tract is working, the gender, body build, if there's chronic disease. If there's other medications on board, concurrent, they're on other medicines. The first pass effect, remember we talked about how fast something metabolizes, if it has to go through the liver or not. Nutritional status, pregnancy, of course, you know what I'm going to say. Everything's contraindicated. And then genetic factors. Immature liver function in infants limits the ability to metabolize medications. We know the aging process can alter liver and kidney function. Differences in hormones, distribution of fat and water, weight, height, and lean body mass can affect medication absorption, metabolism, distribution, and excretion, which we talked about, are all the pharmacokinetics of drug interactions in the body. Okay. Psychosocial variables, health and illness beliefs, previous experience with medications if they're terrified of taking the med, knowledge base, what do they know about it, cultural beliefs. That can be all over the place depending on their experience and what they've been taught, what their family does. Developmental stage, again, we have children that are in trouble developmentally. We really need somebody in there to help us with them. Okay. So administering medications, always, and you notice that I've bolded this, obtain all necessary objective data before administering medications. So what do I mean by objective? It's something that we actually can record. It's not something that somebody said. Example, apical heart before giving digitalis. We have to get a heart rate on the chest. We want that apical heart rate. Any antihypertensives, you cannot give a blood pressure medication without checking the blood pressure. And it's not okay to say the nurse's aide took it 2 hours ago or an hour ago. If you're standing at the bedside and you're going to give an antihypertensive medication, because we may be dropping the blood pressure out. So we have to make sure that the blood pressure is in the range that the doctor wants it in before we give the antihypertensive. Blood type of mother-infant before giving RhoGAM. If the mother doesn't have a negative Rh factor, she doesn't need RhoGAM. Or if the mom has a negative Rh factor and the baby has a negative Rh factor. Sometimes it's ordered anyway just because the mother has a negative blood type. But if the baby is negative, we don't need to give it. And you'll learn about that at a later time. But if the baby has a positive blood type, then we will give it. Electrolyte levels prior to giving them, such as we always want to check the potassium if we're giving Lasix. Lasix is one of the most powerful diuretics that we give today. Old drug, but very effective. We still give it. Washes out so much urine that it washes out the potassium. And we're going to learn in the next few weeks that potassium can affect the heart rate and the heart muscle drastically. So we don't want to wash that out. So yes, they need the Lasix, but let's just check the potassium before we give it. If we're in a normal range, we're good to go. And peak and trough levels we already talked about, so that we're also in that range. It's not going to hurt the patient for antibiotics, so it won't cause deafness or kidney damage. And again, we talked about this already. Here we go again. The 6 rights, you really, really need to know them. Right patient, right med, the right dose of that med, the right time, what route are we going to use? And then we have to document. Resources for medication information, and they're all right here. PDR is the big one, but now you guys have not only so many professional websites or even apps you can download on your phone. So, med class. That may be organized according to pharmacologic action, the therapeutic use, the body system. The action is how the medication works to produce the desired therapeutic effect. And then therapeutic effect, we know, that's the primary action for which the medication is administered to a specific client. It's what we want to see happen, moving them along the health continuum. Adverse effect, again, are undesired and sometimes dangerous effects of the medication. Toxicity have specific risks and manifestation of poison. Liver damage from acetaminophen. We know if you take too much, you can shut your liver down. So there are toxic levels. Remember, we talked about the safety of a drug or not. medication interactions, that can be anything and anything. Precautions, preparation dose, nursing implications, know how to monitor therapeutic effects. That's about the most important one there. Prevent and treat adverse effects, provide comfort. Medication errors, wrong medication or IV fluid, incorrect dose or IV rate. We have the wrong client, route, or time. Administration of known allergic medications. You forgot to check the allergy. We went ahead and gave the penicillin anyway. Omission of a dose. A lot of people do not think this is a medication error, but it's a big one. If you omit a dose and they don't get it, means we skipped it. That's an error. And then the same thing, incorrect discontinuation of medication or IV. We just stopped it. That would be along the lines of omission also. Safe administration of medication typically takes place in the home and community-based settings. Careful reassessment is necessary to determine a client's suitability for safe self-administration. You know, if they're 85 years old, can they see? Can they see the medication? Can they see to be able to draw it up, or can they be able to count the pill? We need to give the client instructions for each medication, both written and verbal, because we all know that sometimes when you tell somebody something verbally, they may forget it. And schedule follow-up visits. Okay, well, I hope this helped, and I will see you next time. Have a great day.